So we'll go ahead and get started now. I just thank you all so much for being with us today. We are very grateful to have Dr. Cynthia Thaik here volunteering her time to talk to us about mastering POTS, understanding its mechanisms and lifestyle approaches to symptom relief. So before I introduce Dr. Thaik, I'm just going to take a moment to introduce LADN in case anyone is unfamiliar. We are the Los Angeles Dysautonomia Network. So we are a 501c3 nonprofit serving people impacted by dysautonomia in Los Angeles and California. We provide support group meetings for dysautonomia patients and caregivers so they can come together to exchange understanding and resources with people going through similar challenges. Our next virtual patient support group will be on December 7th with our caregiver support group on December 9th. So I hope you will join us. We are also very excited to be adding a team group in the new year. So community is at the forefront of what we do, and to help ensure that no one feels alone on this journey, we foster connection through in-person gatherings, our Sick-Lit book club, our mindful movement classes, and our LADN Links peer networking program. I hope you can all join us on December 13th for our virtual mindful movement class, and December 14th for our White Elephant holiday party in Pasadena. We also offer educational workshops like the one you are all here for today. Knowledge becomes especially powerful when it is in limited supply, and I'm sure we all know that dysautonomia has a tendency to provide more questions than answers. So we hope our series of workshops helps provide some guidance. We also offer healthcare access grants. Many of our members face serious financial burdens due to this illness. Dr. Thaik, I will mention that you're sharing your screen now, so we can see the slides and everything. So we also offer healthcare access grants. Many of our members face serious financial burdens due to this illness, and financial barriers should never prevent anyone from accessing medical care. So at LADN, we award healthcare access grants annually to help low-income patients in California access vital healthcare. We now serve over 400 dysautonomia patients and caregivers. In the last year, we have increased our programs and doubled the number of people we serve. As a result, we are busier than ever, and we need more support for our staff. If you are able, I hope you will consider making a donation to LADN. If everyone who registered for this webinar today donated just $20, it would support our support group programming for a month. All right, so now I will move on to today's webinar. And it's my pleasure to introduce Dr. Cynthia Thaik. Dr. Thaik is an internist and cardiologist and the author of the book, Your Vibrant Heart, Restoring Health, Strength, and Spirit from the Body's Core. As founder of the Holistic Healing Heart Center, she combines her extensive training in traditional Western medicine with a wide array of evidence-based alternative therapies. Having trained at two of the country's most prestigious medical schools, Harvard University and the University of Chicago, Dr. Thaik seeks to understand and treat the root cause of health issues and focus on prevention. She understands how lifestyle choices, environmental exposures, and genetics uniquely influence each patient's health. Her therapeutic recommendations draw on extensive modalities, including the latest in advanced cardiology diagnostic tools, nutritional support and supplements, lifestyle, sleep patterns, and mindfulness practices. So Dr. Thaik will be presenting on mastering POTS, understanding its mechanism and lifestyle approaches to symptom relief. After her presentation, we will have a question and answer session. So if you could please put any questions specifically in the Q&A box, which is bottom of your screen. That way we can ensure that the questions don't get lost amongst the rest of the chat. This workshop is meant to provide educational information and is not a substitute for medical care. Dr. Thaik cannot provide medical advice to patients in the Q&A session, so please try to ask broader questions rather than questions involving your specific medical case. And as always, please consult your medical team before implementing anything learned in this presentation. Thank you all so much for being with us. Thank you, Dr. Thaik, for being here. We're very grateful, and I will now turn it over to you. Go ahead and share your screen, and I will leave it in your hands. Dr. Thaik, I also see that we got a comment on the chat that your volume is maybe a little bit low. So I don't know if you want to test that.
I haven't started speaking yet. Can everyone hear me? Can you hear me?
It sounds fine for me. In the chat, if you'd like to let us know if you can all hear Dr. Thaik, okay, that would be great.
Well, thank you, Sally, for inviting me. I know that POS is a topic that is generating a lot of interest. Certainly, we've seen an uprise in the number of patients being diagnosed and presenting with POS, particularly as it relates to the pandemic. I think that's part of the reasons why we had such a uprising of that. Oh, let me put it into side mode. I do want to start off by saying that I am going to come from a holistic perspective. And so some of my teaching and my approach might be different from other providers that the patients might be seeing. That doesn't make my approach necessarily the better approach. I think that it's just a different perspective. We're going to be defining what POS really is, understanding its underlying etiologies, the associated conditions around it. I will talk a little bit about mast cell activation and Ehlers-Danlos syndrome, which are the two most common associated conditions, but there are definitely many other underlying etiologies. We will talk definitely about an integrated model, focusing primarily on lifestyle approaches, but I will definitely touch on different pharmacologic therapies as well at the end. So when I ask Google AI if POS is a disease, the answer that comes back is an emphatic no, right? So POS is not a disease, but more a group of symptoms that occur together. It is a type of dysautonomia, which is a disorder of the nervous system, and its presentation and the autonomic nervous system controls all sorts of bodily function. But the one that is most prominent, at least for the patients that come and see me, is really the heart rate and the blood pressure, which is also very easy to measure and leads to a lot of the symptomatology. So what exactly is POS, right? So POTS, postural just stands for change in position, going from a supine to a standing position. Orthostatic really means upright posture. Tachycardia is a fast heart rate. And syndrome is really, highlighting that is a compilation of symptoms. It isn't just about the heart rate and the blood pressure. It's estimated that 1 to 3 million people in the United States have a diagnosis of POS, but truly that estimate is double and probably even more so since COVID. I also attribute the fact that we now have a lot of voices around POS, such as the LADN, and so it's certainly giving patients an opportunity to find community, share their experiences, and therefore educate and let a lot of people who maybe otherwise have been out there suffering with symptoms come to attention. Okay, 80% of the patients diagnosed with POS currently are women. Usually is post-teen, 15 to age 50. There appears to be a bias right now in terms of the majority of them are Caucasians. And there's still being studies done as to whether this is related to a genetic component, whether it has something to do with the nephrology versus just access to care and knowledge and exposure. As I mentioned before, the prevalence is rapidly increasing, particularly in the post-COVID era, and we'll talk a little bit about that as it relates to the underlying etiology. And as you can see, in terms of the NIH and the estimates that are out there in the literature, is a pretty broad range, right? 2 to 14% developing POS, 9 to 60% developing POD-like symptoms. And a lot of these POD-like symptoms are non-specific, and so it can overlap with a lot of other disease conditions. So what exactly is POTS, right? So when someone is in that supine position, and I apologize, I don't have a cursor that I can move. I usually like to tell patients that you have blood to the brain and to the feet at the same time, right? And so when you're in a supine position, you have a lot of cerebral perfusion, and in fact, probably a little bit more than would like, because actually 30% of the fluid comes back into the heart. And so the heart has a lot of volume to fill. But when you get up into that upright position, you actually lose about a liter, 500 to a liter, into your lower abdomen and to your periphery. And so, in essence, the brain gets a lot less perfusion. Now, your autonomic nervous system is designed to immediately, instantaneously correct for that. And so the vessels will constrict, and then when you can't have enough blood to the brain, then the heart will pump faster in order to get that perfusion up. And that happens in all of us. I don't care whether you are, a 3-year-old or an 80-year-old, right? That mechanism is there as physiologic. For a young individual, that response is instantaneous of the vessels constricting and the tachycardia happening. And typically in a normal response, you get about a 10 to 15% increase in the blood pressure or in the heart rate, and about a 5% increase in the diastolic blood pressure. Now, aging is the number one reason why that response decline. And that's why as people age, you see your 70, 80-year-old grandparents, they walk with a walker. They pretty much want to lie down all the time, right? What is, disconcerting to people who have, POS or postural orthostatic tachycardia syndrome at a young age for various etiology is that you're feeling like grandma or grandpa, but at a young age of 20, 30, 40, right? But the cerebral perfusion or the lack of cerebral perfusion or the diminution of cerebral perfusion is the predominant reason why people feel as poorly as they do. Now, there are definitely other mechanisms involved as well. So what exactly is the diagnostic criteria for POTS? It is an increase in heart rate of 30 beats per minute within 10 minutes of a tilt or standing, at the same time that the orthostatic blood pressure remains unchanged. Okay. Now, this last point is a really key point in that the symptoms of there needs to be symptoms. So, in other words, if someone has the hemodynamic findings of the heart rate increasing in the absence of symptoms, then we wouldn't say that this fits into postural tachycardia. We also would want to have these symptoms be present for at least 3 months. And that chronicity is actually a really important point, because anyone, when we talk about dysautonomia or dysfunction of the autonomic nervous system, that can happen pretty rapidly with any type of acute illness. So you can take even a young, healthy individual, give them a flu, put them in bed for 2 weeks. And when they first initially get up and start trying to move around, they would have developed deconditioning within a short period of time. And you can see, symptoms of the dizziness and the tachycardia. But that wouldn't necessarily put them into the category of diagnosis of POTS, right? So you need that 3 months of chronicity. So in other words, after the body has had time to heal, right, time to readjust and reacclimate, do you still have these symptoms? And it's that failure of the autonomic nervous system at that point to be able to regulate. What are some differential diagnoses? So in other words, other mimickers of postural orthostatic tachycardia. A big one is neurocardiogenic syncope or vasovagal syncope. I like to tell patients that's the normal simple faint, right? This is the type of physiology that happens when patients go and get their blood work drawn and they feel nauseous, queasy, dizzy, and then they might or might not pass out. Same thing, the dental, the dentist and the drill. Those are sort of classic examples. But in this case, the physiology is different because you have both a drop in blood pressure, but also a fall in the heart rate as opposed to the tachycardia. And the other big differential is of orthostatic hypotension, where you have, this is just somebody who's, dehydrated or who has acute blood loss, diarrhea, something of that nature. And you will have a fall in both the systolic and diastolic blood pressure along with the tachycardia. So those vital signs are critical, whether in your own home taking these assessments, at a doctor's office, or more formally when we do a tilt table test. So what are the mechanisms around underlying POTS, right? And here I really want to stress that there are overlaps, and so it is never just one isolated mechanism, okay? So hypovolemia, or relative lack of blood volume, is as a really key contributor. And I tell patients, no matter what other underlying etiologies you might have, this is always a contributor. And it's estimated that it contributes up to 70% of POTS patients where dehydration. And just so you know, the World Health Organization has deemed that, about 70% of the world is like chronically dehydrated. And I will talk more about exactly how much volume you need to maintain adequate hydration. But you'll be surprised that even conditions such as mast cell activation, apologies, what just happened? Oh, all right. I don't know how to shut that off so that it doesn't ring like that. I'm going to actually try and turn my phone off and see if that might make a difference. Okay. So even conditions like mast cell activation syndrome and Ehlers-Danlos will fall into this pathophysiology of hypovolemia, and I'll explain that more later. Then there's the neuropathic, which is basically peripheral denervation, basically the nervous system or the nerve and the peripheral blood vessels and muscles don't work adequately. And typically you see this in diabetic patients or people who have degenerative neurological conditions. Certainly the elderly people, as we age, also will develop some nerve denervation. Hyperadrenergic POTS. This is a more unique subset where patient has this excessive sympathetic nervous system drive. There's an increased adrenaline drive that's causing the tachycardia. And again, with hyperadrenergic, you want to make sure that volume and other issues aren't playing a role, because obviously the sympathetic nervous system is designed to counteract these other perturbations. And so if you are hypovolemic and if your blood pressure is low because you don't have enough perfusion, the body will activate the sympathetic nervous system and you'll have that tachycardia, but it would be a compensatory mechanism. So the hyperadrenergic physiology would be if it was in isolation. And we certainly have had, we can in a more of an academic, more research setting, test for your epinephrine or epinephrine level and document patients who are like this. I do want to point out that there are some drugs that will, by its very nature, lead to a hyperadrenergic state. So the NET stands for norepinephrine transport. So it's a uptake of the norepinephrine, which is constantly cycling within the body. And so tricyclic antidepressants will inhibit that reuptake, and so lead to more norepinephrine being around. Same thing with Wellbutrin, it inhibits the reuptake mechanism. And then obviously drugs like Ritalin and medications that people might be on for ADHD are naturally sympathomimetic. So they will act in the same way as your endogenous epinephrines. Now, a word about autoimmunity. I think that every patient who presents with POTS or POTS-like symptoms should definitely be asking their primary care provider, their internist, to check for autoimmunity. It is a very much of a key predisposing factor within the POTS arena. And so, at least for my patients, if patients haven't had this screening done, I will typically check for thyroid autoantibodies. And just to be clear, a lot of physicians will check a TSH or check a T3 and T4 and will tell patients that your thyroid is fine, right? It's not an issue. But unless they are actually checking for anti-TPO and anti-thyroid globulin antibodies, which are antibodies specifically against thyroid tissues, you can have a normal TSH, a normal T3 and T4, and still have thyroid antibodies that are quite high. Same thing with checking ANA to look for collagen vascular disease like lupus, Sjogren's. Sjogren's is actually quite common among patients who have postural orthostatic tachycardia. And then, as I mentioned earlier, physical and cardiovascular conditioning is also a big contributor to this mechanism. So going back to the slide that I showed earlier of the positional change, when you are standing up, okay, and blood is pooling to the lower extremities. The reason that conditions, well, I'll circle back to that, but conditions like mast cell and Ehlers-Danlos will contribute to the hypovolemia. I will explain a little bit. But here are the symptoms that are associated with postural orthostatic tachycardia. In addition to just the dizziness and the lightheadedness and the tachycardia, patients will often feel sweaty, shaky, nervous, weakness, fatigue, brain fog. They will often complain of chest discomfort, shortness of breath, and the palpitations. While some of these symptoms are associated directly with the heart rate and the blood pressure, a lot of these symptoms are also coming about as the result of the dysautonomia or the dysregulation. Now, to talk about the other two conditions, mast cell activation syndrome and Ehlers-Danlos syndrome, I think that for any patients who are coming in with POTS symptoms, it's really important that their physician is thinking about these two other conditions. So what is mast cell activation? So mast cells are white cells that are released when someone develops a type of allergic, environmental, food, respiratory exposure. And they often then, these mediators will be released, histamine, serotonin, prostaglandin. And what these mediators do is actually cause what we call a leaky barrier disease. So it's a capillary leak syndrome. Okay, and here are the symptoms that are associated with that. And just go back, if you look at the prevalence, right, that's reported in the literature, it says the prevalence is reported as as frequent as 1 to 6 to as infrequent as 1 to 1,000, right? So when I saw this, and I'm not a mast cell specialist, but obviously with my evaluation of patients with POTS, I was, researching this. And the reason why this prevalence is so wide, okay, is because it depends on how you want to define mast cell activation syndrome. If you want to go strictly and have the laboratory or the biochemical evidence of someone having mast cell activation, yeah, absolutely, it's going to be rare to make that diagnosis. And I'm sure a lot of your audience have gone and seen patients and asked this question about whether, they think mast cell activation could be part of the picture, and inevitably the primary care doctor or even an allergist immunologist will say like, oh no, I don't think that's what you have. I tend to be not as dogmatic in terms of the actual diagnosis, but more in terms of the clinical symptoms, okay? Because diseases, when you really think about it, is a spectrum, okay? It isn't an absolute where you say you don't have it or you have it. And what it, because the physiology is really involving a spectrum. So as an example, for myself, right? I have a lot of rhinitis, sinusitis. I get drippy, runny nose all the time. Doesn't happen all the time, maybe, you know, 2 days out of the week, and it would come on randomly, right? Then, you're blowing your nose, you're sneezing, you have this allergies and so forth, right? I can tell you that I can't walk into Home Depot and go down the paint aisle. I will break out in a rash, urticaria, right? So just by me having those two classes of symptoms, right, I know I'm part of the mast cell activation spectrum, right? Now, do I have a formal diagnosis? No. Have I ever gone and gotten my tryptase tested? No, right? But what I do know is that in those time period where if I have an urticarial reaction to a chemical, and it's not just paint, household ingredients, cleaning agents, or if I start having hay fever and sinus symptoms and allergies, I can absolutely know that mast cells are being activated at that point, right? That's the very essence of why you have that runny, drippy nose, because these histamines and so forth are being released. And I also have POTS symptoms, and every so often I have irritable bowel, right? So if people look at these symptoms that are listed here, and if you have symptoms at various times in two systems, right, whether it's respiratory and cutaneous or cardiovascular and respiratory, if you have a history of asthma, childhood asthma, if you have seasonal allergies and so forth, you can absolutely know that at some point some of this physiology is playing a role. Okay, and so I do encourage my patients, if they are suspicious of this, right, they can go to a physician and seek attention or try and get a formal diagnosis, or they can also just empirically, right, and I don't say this lightly, but because these drugs are available in the um, as in CVS, Rite Aid, as over the counter supplements. I do encourage my patients, if they, especially if they have the respiratory symptoms, that they can try H1, H2 blockers. Allegra, Singular, Claritin, and for the ones where mast cell activation is playing a role, I've had patients report to me, yeah, I started taking, Singular or Claritin for my allergies, my sinuses, and I noticed that my heart rate wasn't as fast, right? And so you will definitely see that as an issue. And the reason for that is that when these mast cells are activated, right, then you have this leaky barrier. And not only that, but you have this vasodilatation. And so in a moment, your body can become more dilated, right? And so it's going to produce what is the physiology of hypovolemia. Okay. And I would say to patients at that point, right, rather than treating the heart rate or the blood pressure, right, because those are compensatory response, you have to treat the underlying condition. You have to go after the mast cell activation, because that's the thing that is driving the physiology of why you're having the symptomatic presentation. Okay. So this is the effect that histamine has on the cardiovascular system. It increases the heart rate and the force of contraction. The way it does that is that it activates the H2 receptors in the right atrium and the H1 receptor in the left atrium. And so again, just highlighting that empiric treatment, H1, H2 blockers. So the Singular, Allegra, Claritin will be in the category of the H1 blockers. The cimetidine and Zantac, which are more for the GI tract, would be considered H2 blockers. And the histamine, in addition to causing leakiness and permeability, will cause dilatation of the blood vessels and lower the blood pressure, and it leads to endothelial barrier dysfunction, leading to capillary leak. So again, your blood volume becomes less and less. Now moving on to Ehlers-Danlos syndrome. Just to go back and talk about that, this is an abnormality of the connective tissues or joint hypermobility. There is the Brighton scale, which I will go back to make the diagnosis. There's between a 20 to 50% association with POTS. And this is a group of inherited disease. And so again, while you can go ahead and try and get genetic testing, there are hypermobility Ehlers-Danlos-like syndromes where you're not going to have the genetic component of it. So again, I always go by the physiology. The prevalence, again, really broad between 1 to 50 versus 1 to 5,000. So it really depends on how strict you want to be and how you want to define the diagnosis. But again, for me, it's more about the physiology. So if you have laxity of your connective tissues, if you're able to literally bend your thumb like that, right? So that's one of the indicator. Your pinky backwards, your hand at the elbow, your knees. If the joints are hyperlax, then this is a defect in the connective tissue. And so if your connective tissue, and you can also, look at your skin, if you have hyperlaxity of the skin, then your capillaries and your blood vessels will also be hyperlax, okay? And so what that essentially means is that if you start off as a person with this small 33-ounce bottle, right, that's your container, right? While you as an individual and your exterior container doesn't change, if you have a mast cell activation or histamine response, or if you stand up and your capillaries, instead of being taut and holding that container volume, starts expanding, then you can literally go from that 1 liter container to a 3 liter container or a 5 liter container. And so your relative blood volume will then decrease, right? And that's really important because I always explain to patients, especially the ones where I'm talking to them about hydration, and they're saying, I'm drinking so much water, I'm drinking so much water. And I explain to them that it depends on what your body situation is at that moment in time. And so your volume and your volume need might change depending on if you have hypermobility, depending on if you're having an allergic or mast cell activation response, right? And so you can literally go from, I usually like to say, from a wading pool to a swimming pool to a dive pool to a lake to an ocean, right? And so you can see the magnitude of changes in those blood volume or those containers. Now, what are the other comorbidities besides the ones that we just talked about, the EDS and the mast cell activation? Any type of autoimmune disease, whether it's Hashimoto's, lupus, Sjogren's, rheumatoid arthritis, celiac disease, anything that's infectious and inflammatory. Right now, we're seeing a lot of POTS patients coming out as a result of the COVID pandemic. But previous to that, it had less of the definition of POTS, but more, it goes by different name: chronic fatigue syndrome, chronic myeloencephalitis, right? And we used to see this for patients who had like post-mono, post-EBV, post, viral illnesses. But in the past, right, there used to be a patient here, a patient there, because these infections and these inflammations were happening randomly. I think that the one thing that COVID did for this, condition is that because we had a pandemic, because we had this like concentration of patients who were having this infectious inflammatory response, endothelial dysfunction response, all of a sudden we saw a huge rise in patients presenting with this condition. And it was hard for, doctors to sort of not take notice and not like recognize it because all of a sudden we were seeing all these patients. And I think that with that, there's been a lot more interest in the medical community and the research community to try and understand this condition a lot better and to find treatments or solutions for it. Okay. I'm going to move on to diagnostic testing now. And so the NASA lean test is something that we do in the office. And this is also something that you can do in the home. You just need a good blood pressure cuff, right? And so basically taking a look at your blood pressure and pulse lying down and then standing and typically we want to do a lean. And so, you can go and stand against a wall, stand about 6 feet away from the wall and just lean back, and let your shoulder blades touch the wall. You don't want your butt to be touching. You don't want to be upright like this, but more of a lean. And just checking your blood pressure every minute and checking your pulse, right? And so you can see the difference in these two, patients that were in my office. One where you could clearly see that the heart rate, it jumped and then steadily continued to increase. So they definitely need that 30-point heart rate increase while the blood pressure was maintained. Versus another patient where the heart rate and the blood pressure remain steady, right? Now, when I see this negative test, I'm quick to reassure the patient that that doesn't mean that they don't have the symptoms that they do, right? Because their presentation, what they experience, is their symptoms, right? What is all is saying is that at the moment that I'm testing the patient, that they're not manifesting hemodynamic changes or dysautonomia related to whatever the underlying issue might be, right? And I do know that a lot of doctors, and even if you look up NASA lean test and see how to do it, they will typically advise that someone restrict their oral intake the day before to a liter, that they don't take medications that they would normally take, and so forth, in order to sort of bring out the response, right? And for myself, I don't do that. And the reason I don't do it is because I want to meet the patients where they are. I mean, our ultimate goal is to try and get you to be less symptomatic, right? To be able to see that these therapies that you are doing is effective, right? And so when someone comes in and we don't see a heart rate response, then I'm saying good, that means that you are maintaining your volume, that at least from a hemodynamic perspective, your symptoms are not manifesting in this manner, right? And that's going to be our ultimate goal because, as I said before, POTS is not a disease with a specific type of treatment that can be cured. POTS is a condition that waxes and wanes. And so it's really important that we learn how to manage and mitigate our symptoms. That's what this is all about. I'm going to show you a couple of testing that we specifically do in our office that gives me a little bit more insight into an individual because it truly is difficult to tell just from symptoms. And even when we do the heart rate and the blood pressure, that isn't enough data to really let us know what's going on internally. So this is an impedance cardiography. I tell patients EKG, which everyone's familiar with, looks at the electrical activity of the heart. ICG looks at the hemodynamics, the pipes and the pumps of the heart, okay? So the first two bar are the heart rate and the blood pressure. That's what every doctor gets to see, but I get to see a ton of other parameters. And I'll just go over them really quickly. I apologize, I don't have a cursor, but stroke volume and cardiac output are basically how much blood per heartbeat. For each individual heartbeat, how much volume of blood you're putting out, and then cardiac output is liters a minute. The next two bars after that is systemic vascular resistance. That's basically telling me, is your blood vessel super dilated? Is it super constricted? Or is it just right? The next two are velocity and acceleration index. That's telling me just how fast is your heart pumping, how much adrenaline is involved. And the very last bar is your thoracic fluid content. That's your preload. That's basically how much blood is coming back into the heart. Now, understand we do this test while someone is supine. which means the blood volume from the leg and the abdomen is already fully into the heart. So this is as good a preload or thoracic fluid content as you're going to find. And then when you stand up, you can suspect that that's going to be less. We typically want all the bars to line up exactly in the middle, so in that second box. And so in this example, you can see that the thoracic fluid content is low. And so this is an example of a patient who has less blood volume than is necessary to support her. In this example, the two bars that are extremely to the right, that's velocity and acceleration index. So in this individual, they're coming in with the tachycardia, and I can clearly see that the velocity and acceleration index is suggesting to me that they have a high adrenergic tone right there, whether they're just anxious and nervous being in the office, or whether they have a heightened norepinephrine, epinephrine response. And this example is showing that the systemic vascular resistance is elevated, which means that this vessel is super constricted, right? And if you look at these individuals, their heart rate and their blood pressures are fairly similar, and you wouldn't necessarily know what the underlying mechanism is without this test. Another test that we do in our office is to look at vascular flow. And we look at it by measuring capillary flow at the fingertips. The top example, the two blue bars, is both the right and left arm, just looking at the volume of flow that's coming through the capillary. And then in that bottom blue bar there, the second blue bar, halfway through, we pump up the blood pressure cuff and we occlude the arm. We occlude blood flow in the one arm, and then we look for the response afterwards. And you want to see this post-constriction dilatation. So the top example is somebody that is, normal blood flow. And in the bottom example, you can clearly see that that individual has a much more constricted blood flow. And that's blood flow that we're looking at in the nail beds, right? So this is a peripheral assessment. Now, we obviously don't care that much how much flow is that they have in their fingertips, but this would be a representation of what the blood flow would look like in their brain, in their heart, in their lungs, in their kidneys, etc. Because the microvascular circulation or the capillary fill is influenced by whatever is going on within your body, whether it's elevated blood sugar, whether it's stress and cortisol, whether it's infection and inflammation. And so if you're constricted to the periphery of your fingertips, this is also what your brain is seeing in terms of blood flow. And so this is an explanation I often see with patients when I test patients with long COVID who are explaining brain fog, and we see a constricted blood vessel like that, okay? But here's another example, right? And so again, I have the normal in up at the top, and you look at this individual, right? They come in and they look perfectly normal. The first 5 minutes is identical to the upper example, okay? And in that second 5 minute, we took that blood pressure cuff and we occluded the one arm, right? Look what happened to the other arm at the same time, right? At the same time, we're occluding the one arm, that other arm and the flow of that other finger expanded incredibly. I mean, like if you look at the end, that's probably at least 5-fold, if not 6-7-fold increase in blood volume. And that's in a single cap or a single finger. Now, if you can imagine if all the capillaries in your entire body was expanding like that, that's what I mean when I say, did your body just go from a pool, a lake to an ocean? Did you just massively vasodilate? Okay, and this is a test that we did over 15 minutes in 5-minute segments. And you can see how profound, how profuse this response is and how robust this is, right? And so part of us doing these testing and part of me showing these as an example is that I want people to understand just how robust. I'm always amazed when I see this, right? I'm always amazed at our body and our physiology of how instantaneously we can change and respond and react. to a lot of different things, right? But in this case, obviously, is to a stimuli on the one side, but the patient's thoughts and her emotions were probably playing a big role in that vaso expansion. Okay. The third thing that we do is looking at autonomic nervous system testing, right? And just a quick education on that. There's the central nervous system, that's the brain. There's the peripheral nervous system, that's the spine and the lower extremity and the extremities, right? And within the peripheral nervous system, we have the sympathetic, parasympathetic. Sympathetic is the fight and flight. Parasympathetic is the rest and relaxation. Okay, and so we oftentimes naively think that if someone has a really high sympathetic tone and a low parasympathetic, that they're going to be high stress. But if you can see from these two individuals and these two separate patients, they both are very much sympathetically dominant. That's the red bar under SNS, and the parasympathetic is low. But if you look at the first patient, they have really good heart rate variability. That sine wave up at the top under HRV is heart rate variability, and the other person less so. So the stress score of 33 versus 62, I tell patients that's like the speedometer in the car. Are you going at 30 miles an hour? Or are you going at 60 miles an hour? So in the face of having a sympathetic overdrive, one's been able to downregulate and have a low stress versus the other person who still has a high stress. On the flip side, parasympathetic, we're always talking about we want to increase our vagal tone, increase our parasympathetic. But look at these two individuals. They were parasympathetically dominant people, right? But again, depending on whether you have cultivated good heart rate variability versus not, someone has a stress score of 30 and someone has a stress score of 77, despite the fact that they have a high parasympathetic. So I don't want patients to think that just because you have a high vagal tone that you're going to be low stress. They don't correlate in that manner. Okay. And then the last thing that we do is the Ewing test, which actually looks specifically at heart rate variability when we do the various maneuver. And just for the interest of time, I'm going to move on quickly. But if you look at this individual, we do different maneuvers, deep breathing, Valsalva. You can see this individual where they have a lot of heart rate variability. If you look right under the word Valsalva and straight down, there's a lot of jaggedness to that individual, okay? And then you can see as you move to the right, when they stood up, when they were standing, that heart rate variability completely went away. And then when they sat down, the heart rate variability showed up again. And then when we look at sympathetic and parasympathetic nervous system tone, when they were doing the deep breathing, which is to lower their sympathetic, they had a sympathetic index of 1.45. And then when they did the Valsalva, which increased their sympathetic, it went to 4.79. When we did the lying and standing, the sympathetic index is 0.3 when they were lying. And then as soon as they stood up, the index went up to 9 or 6. Okay, so this individual's sympathetic nervous system really took off as soon as they stood up. Here's another individual where you can see the heart rate variability continued whether they were doing the lying or the standing. And in this one, if you look at the sympathetic, when they were lying, it's 0.03, and then when they stood up, it went to 0.9 with 2 standard deviation or up to 2 being the standard deviation of the majority of the people. And so this is highlighting the difference between someone who has cultivated their heart rate variability and was able to manage their autonomic balance. And I'm just going to skip these. And so this is an example of the Cubios, which is the app that I use on the polar. These meetings that I've been doing slowly, and I just wanted to just sort of point this out to you, say that on a daily basis, your hormonal can vary.
Dr. Thaik, I think we're having some connection issues with your internet. And it looks like you're back now. You froze for a minute there.
Okay, okay. In terms of how much fluid one should be drinking, we typically like to encourage people to take 50 to 70% of their weight in ounces, okay? And so it's a pure mathematical formula. The reason that we do this, if you look at these various organs in your body, most of our tissues have 50% or greater percentage of water content. So for example, the brain is 73%, the muscle is 75%, the blood vessels is 90%. So there's only two organs that are less than 50%. One is the fat adipose tissue, which is 10%, and the bone, which is 30%. And so we typically, as just an average, round off and say 50% of your weight in ounces is a good estimate. But for the patients who are more leaner, my small, thin women, you should, and if you have POTS symptoms, you should be drinking closer to 70% of your weight in ounces. Whereas my larger individuals can, do 50% of their weight in ounces. Okay. But that's the general rule. I think minimally for anybody with POTS, they should be drinking up to 3 liters a day. Okay. And part of the reason they should be drinking up to 3 liters a day is that you have this daily water loss, right? So even if you weren't drinking any fluids at all, your urine is going to be putting out between 500 to a liter of fluid a day. You also lose fluid in your respiration, in your sweat, and not even just sweat, just ambient temperature control. You'll be losing, about 300 cc's. So as a good rule, as an estimate, we typically are losing about 1.5 liters of fluid on a daily basis. So minimally, you have to replace that and then some, okay? Just a word about salt and hydration. I do think that, for people who have low blood volume, it is important to salt load, but a caution about that, right? Salt is an osmotic. Its goal is to draw fluid into the blood vessel. You have to give volume with the salt. This is the World Health Organization, and you can just Google the oral rehydration solution. This formula will come up. This is the hydration that I typically would recommend my patient, even though I do know that there are different, consumer formulations that are out there. But the mistake that I think a lot of people are making is that they're taking the salt in a small glass of water, chugging that, and expecting that to do its trick, right? The salt will do its trick. It will, as an osmotic, draw fluid into the blood vessel. But guess what? If you don't give it the several liters of water exogenously, it's going to draw the fluid from your brain, your muscle, your lungs, your other organs, because that fluid has to go into the blood vessel. Otherwise, you're going to be hypotensive or tachycardic. And so the salt is going to do the osmotic load, but you got to give it exogenous hydration. So again, plain water, a little bit lightly salted. The oral rehydration solution is to be used for acute dehydration, or typically when I advise my patients, I tell them you can go ahead and use it 3 days in a row just to increase your volume. But if we're doing that, I want to do it as a diagnostic so that make sure they're measuring their heart rate and their blood pressure as they're doing this. And they also, it's really important for supine hypertension. And so it's really important that you front load your hydration, that you get a liter as soon as you wake up in the morning, second liter maybe by like 11 o'clock, third liter by 3 or 4, and then actually don't encourage fluids after the dinner meal, because when you become supine, you're literally going to send this ocean fluid back to your head and back to your brain, and that's not a good thing, okay? The other thing about oral hydration, you want to make sure you don't do it around your meals, right? That's the habit that we have. We eat, we drink with our meals, but when you do that, you're really hydrating your mashed potato and your broccoli and not getting that fluid into your body. Compression is another thing that I think is super important, particularly people with mast cell activation or Ehlers-Danlos. People tend to wear stockings at the lower extremities, but we know that abdominal binders are the most effective, and then upper thigh and then lower thigh. As far as abdominal binder, it doesn't have to be the medical grade. You can just get like your standard garment compression. and those capillaries, because they are low pressure, will compress. And you can see this graph here of when they did the study, the heart rate definitely improves by almost 20 points when you're doing that compression, full compression. And then there are counterpulsation maneuvers, which I think a lot of patients have figured out on their own. But if you haven't, you can definitely use your peripheral muscles to help to constrict those blood vessels and pull the blood back up to your head. Okay. But I always tell patients in the crisis, the best thing you can do is just lie down, right? The head has to be at the same level or lower than your heart. And then exercise. I can't stress to you the importance of exercise. As I said to you, even if you take a young, healthy individual, put them in bed for 2 weeks with a flu, they will develop deconditioning. So peripheral decondition happens very rapidly. And unfortunately for a lot of patients with POTS, because they're so symptomatic that they can't do very much, they end up, not doing a lot of physical exercise. And so it's really important that you get into an exercise regimen program, whether you can, through your insurance, get access to OT and PT to help you, or whether you on your own start doing supine exercises, and that can be, swimming, recline rowing, and then progress up to biking prior to, upright standing and running. You want to do aerobic exercise, 30 minutes, 3 times a week, as well as resistance training. And I do tell patients, while POTS isn't like, like a post-stroke patient, the same way that if someone has a stroke and has to slowly rehabilitate to get their entire system, not just the peripheral muscle, but their brain connection to the muscle working. I think patients with POTS have to think in that similar vein, that they need to commit to regular sustained exercise to recondition their body and to get the carotid baroreceptor to start making those connections again. And so I recommend to patients either the Children's Hospital of Pennsylvania POTS protocol. All of these images come from that, and it's right on the internet and easy to get to and implement. The same thing, the Utah ADAPT protocol was put out there just this year, and that's another protocol that you can follow. This is a technique that actually it can be quite helpful to patients. Again, we're trying to avoid that acute change. And so when you're lying completely supine, you have all that blood to your brain, and then when you stand up, is a significant change in that physiology. And so if you can put the head of the bed up, and we use this for people who have GERD or other, symptoms of reflux, but you can just put the entire head of the bed up, and just even doing that little 6 inches will make your upright posture the next day be improved in terms of their symptoms. Word about the autonomic nervous system. It is the system that is designed to provide homeostasis. It's the yin and the yang, the black and the white, right? So it's the counter of each other. And the primary goal of the autonomic nervous system is to maintain homeostasis. And it does that through all your bodily function, whether it's heart rate, blood pressure, respiration, temperature, digestion. And, it's fight and flight versus rest and relaxation. And so what I tell patients regarding dysautonomia is sort of like, your car driving on that slippery, sleek road, right? Where it's going out of control, right? And when you've had, whether COVID or dysautonomia from autoimmune issues or a leaky gut, when your nervous system isn't working well, at least in that moment or in that phase, right? Whether it's 3 months, 6 months, however long you suffer that condition, it's really important that you hold that wheel tight and you maintain stability. And I think what often happens when patients don't recognize or haven't been properly educated, right, is that when they are symptomatic, obviously they're scared, right? And obviously, they try to course correct, and they try to change direction. And so instead of steering tightly they tend to overcorrect, and then you're going on this way, and then they kind of overcorrect, and you actually end up worsening the symptoms more, right? And so I always say to patients with dysautonomia, if you think about a metronome, right, left to its own, it will settle back to the midline, right? And the thing that you have to do is to avoid the triggers where you're going to tap this metronome again so that it's swinging again, right? And so, what are the common triggers? Obviously, heat, sunlight, anything that's going to cause dehydration. Prolonged standing, but on the flip side, prolonged bed rest, right? And so, again, if you're going to be in bed, at least try and have your head in that reclined position. Exercise, why I said it's good, it does vasodilate. So you want to have a slow, methodical training program. A lot of times, because a lot of patients with POTS tend to be young, they tend to want to speed through the process, right? And I tell patients that's okay to do as long as you don't develop post-exercise malaise. But that's something that you really have to watch for. If you do whatever it is that you do, if you develop malaise afterwards, then you got to draw it back and step back. Stress, alcohol, caffeine, any type of large meal. So I tell people to do small meals, but also not just small meal, but look for food sensitivity, especially if you think that you have mast cell activation. There's the antihistamine or the low histamine diet. There's the FODMAP diet. There's various autoimmune anti-inflammatory diets that you have to do. And then a common thing, I see a lot of POTS patients, and inevitably one of them come back and said, I had my fourth bout of COVID. I was doing well, and now all of a sudden, my symptoms are back again, right? And that's just the nature of this condition. And so one of the things that I do want patients to understand is that it is going to flux, it's going to wax and wane. You will get better, but there are going to be times when you get worse. And when that happens, you just have to recognize that this is part of the condition, and be okay with it, right? And then the last thing is emotional swings, right? Um, um, our emotions does play a role in our physiology. I showed that to you when I showed you that blood vessel that incredibly dilate. That's a thought process that was happening. And so really learning to hold that wheel steady and not rock back and forth is important. Just a word about the well, let me the
Dr. Thaik, can I just,
yeah.
I'm sorry, I don't want to interrupt. I just wanted to mention that we are past 1 o'clock already. So if you could wrap up so that we could go to the Q&A session, that would be great.
Absolutely. Okay. Just a word about Heart Math Institute. Is an organization founded by Dr. Chaudhry, 1991. Its mission is to awaken the heart of humanity. And what they've been doing is basically teaching how to gain heart resilience. And so I really encourage people to go to Heart Math, look at the website. They have tons of data with respect to emotional stability, but really about bringing that autonomic nervous system back into check. Okay, and there's tons of research and support by the medical community. There are different apps like the vagal nerve stimulators that will be helpful as well. But again, that's more third line down the road. Okay, and I think for now, I will go ahead and skip medications other than to basically say that, pharmacology should not be first line therapy. We should be using drug therapy for the more severe refractory patients. We should be using it to try and get patients to be well enough so that they can tolerate a rehabilitation exercise program. And the drugs should be targeted to the physiology. As opposed to just sort of like throwing the kitchen sink at patients. I've seen patients where they're on multiple different drugs. And so I think it's really important to define your physiology and then use drugs to target it. Okay. And let me go ahead and stop there, and then we'll just take questions.
Okay, great. So I just wanted to mention to everyone that You can put your questions in the Q&A box. We will try to get through them all. We already have a lot of questions from people who posted questions in the when they registered for the event. So we'll try to get through them. All right, to begin, I know that you talked briefly about, you talked a bit about hyperadreneric POTS. There's been a lot of interest in how that's evaluated and diagnosed, and any best treatments that you recommend specifically for hyperadreneric POTS.
Yeah. So again, I think that it's really important that we rule out the contributors, right? And so, you can have hyperadrenergic POTS because the sympathetic nervous system is activated, right? And it's activated for any type of imbalance. So volume imbalance, stress emotional imbalance, right? And so you want to try and make sure that you take care of those factors. And if indeed the patient and obviously I've showed you that we have testing. So we actually do look at heart rate variability. We look at the autonomic nervous system. We can actually through calculations see the relative impact of the sympathetic and the parasympathetic tone, right? And so for people who do have hyperadrenergic POTS, we start off with the beta blocker. The problem with the beta blocker is that oftentimes these patients who have POTS have low blood volume, right, and low blood pressure. And so tolerance is an issue. When the beta blockers have been studied in this population, it seems to be age dependent. And so individuals less than 42 years of age tend to not do well and tend to not tolerate the beta blockers. For the subset of patients who are over 42, we do see that there is some benefit. We want to make sure that there's a blood pressure available to be able to use that treatment. When I do use beta blockers in my practice, I use just low dose beta blocker. It is designed to take the edge off the adrenergic nervous system, but not necessarily to control the heart rate. So I think that it is a mistake when we try and push beta blocker to try and control the heart rate, because that's going to vary from time to time, right? So typically, again, not medical advice. You need to be individualized, but I'll use the low dose beta blocker twice a day, and then just measure the blood pressure. Okay, but there are other treatments that can help. There are. Let me just go back here. You can use ibuprofen, which tends to have less of a blood pressure effect. It works by a different mechanism to lower the heart rate. And then there's methodopa and clonidine. They're actually alpha agonists. And so if anything, they tend to constrict the blood vessels. But the way that methodopa and clonidine are used, that they're central alpha one, so they actually downregulate the release of the norepinephrine.
That's very helpful. Thank you. We've had a couple of questions from different people about what to do if you wake up like in the middle of the night with adrenaline dumps and like in the middle of the night tachycardia, and with potentially like waking up with high norepinephrine. So do you have any advice for people on like what to do when they experience this and how to manage those symptoms?
So acutely, right? And this is where I do encourage patients to have like tools and resources that they can get to in the moment, right? Because we can grab for drugs, right? But drugs are long acting and they don't take into account the day-to-day and moment-to-moment variabilities, right? And so having practices that you can absolutely go to, whether it's breath work, whether it's like mindfulness, stillness practices, gratitude, to that is truly like in the moment the best way that people can like sort of lower their sympathetic drive, right? When you are waking up in the middle of the night having this tachycardia, then we know at least volume is not involved, right? Because you're supine, and so it's not an upright issue. So volume is not the issue, right? And oftentimes patients will say like, I'm waking up in the middle of the night, I wasn't stressed, right? But the thing is that we don't know what our thoughts are during, our brain's always active, right? And people tend to think that when they're resting that they don't have conscious thought, but there's, when we study our brain waves, right, where the brain activity is always there. And I think that having tools to sort of like regulate that is super important. And it's a practice. I mean, I'm just going to say it's a practice. The thing that I always tell my patients, right? Pick a tool, pick whatever think works for you, but then you got to practice unbelievable amount of time. I always say like, Shaquille O'Neal or not, Kobe Bryant, LeBron James, the reason they can perform at their level in a game is because they are practicing that tool 1,000 times in the quiescent state, right? And I think that that's where patients tend to miss, including myself, right? Like I had an example today of where I wanted to, this morning I woke up and I didn't feel good, right? I maybe was nervous about, this, giving this talk, and my readiness score was super low. And I literally, had to take like 45 minutes to get myself up to a place, right? By practicing the things that I know how to do. But it isn't easy. But that's, I would far rather that a patient learn to be self-reliant and self-resistant and to have tools within themselves as opposed to grabbing a pill or something of that nature. And the other thing that I do want to reassure, and so part of why we do the process of evaluating the heart, right, is the thing that I want individuals to understand, right? Unless you're an elderly person, unless you have coronary artery disease, unless you have, ischemia, unless you have heart failure, right? Your heart will be able to withstand a heart rate of 120, 130, 140, right? And the key for us is to just like understand that, appreciate that, trust that, and allow ourselves to downregulate so that the heart rate comes down on its own. Because as I said, homeostasis, it absolutely will, right? And of the hundreds of patients that I've tested for autonomic, dysfunction, most none of them have autonomic failure, right? Like that would, that takes a real serious condition, like either type 1 diabetes that they've had their entire life, or neurodegenerative disorder like Parkinson's, or MS, right? But any autonomic dysfunction that comes about as a result of an infection, inflammation, dizzy, gut issues, stress, it is a dysfunction that will regulate itself as long as we give it time to do so and just support it.
Well, thank you for your response. We have some other questions here, particularly about COVID vaccines, COVID boosters, whether there's research showing if it's safe for people with long COVID POTS, and if you have any input on whether any particular types of vaccines are better than others, such as the Novavax versus mRNA vaccines.
Yeah, so the short answer is we don't know, right? And so the thing that I will say for myself personally is that I am not pro-vax or anti-vax. I see the value of it when we had the pandemic and we had, so many patients that were dying and we needed to do something. But at the same time, right now, personally, I've elected not to take any more vaccine, right? I definitely have seen, cardiac injuries related to the vaccine, without a doubt. And I've seen the same way that the, getting a COVID infection can lead to, these POTS-like symptoms. I've seen people post-vaccine who've also presented with POTS-like symptoms. So at this point, I think it's about, sort of weighing your odds and avoiding, situations where you might have, an infectious exposure. Like for example, for myself, yes, I'm not masking, when I see patients. However, when I go on a plane, I still mask. So I make those choices. And so there isn't a right or wrong answer. And I don't think that we should be legislating this at this point. It should be an individual choice. It should always have been an individual choice.
Yeah, it's a difficult question. Wish there were clearer research. Thank you for that input. We've had a couple people ask about, obviously you've spoken on the benefit of exercise. We've had a couple people ask about post-exercise malaise and exercise as a trigger for symptoms. Do you have any advice on how to avoid that and deal with that?
Yeah, so it exercise absolutely can be a trigger without a doubt, right? And so, but I think that avoidance then has the opposite and potentially worse impact, right? And so that's why it is so important that you either work with a professional or get into a true and try methodical approach, right, with respect to exercise. You want to stack the deck, which means you have to be really, loaded up in terms of hydration, right? You want to start really, slow, but always start with supine exercises, right? So just in bed, making sure cerebral perfusion is protected at the same time that you're either doing leg lifts, resistance training, etc., and slowly march it up, right? And for myself, I do like using technology, right, to track, where do I start off? Is today a good day where I think I can handle doing more physical activity versus not, right? And while you might not have sophisticated, software and the tools that I would use, you can still use the similar concepts in terms of heart rate variability to track where your sympathetic and parasympathetic, drives are, and whether your body's going to be able to handle it. But I think consistency is the key, right? You have and consistency and not overdoing it, the key. You know, start methodically, slowly, right? To the point where you're bored with what you're doing and you think I can do so much more. But the reality of it is you have to allow these carotid baroreceptor to re-engage and to learn how to take that volume and load of blood and not react, right? So understand that the carotid body is there as a protective mechanism, right? So in this infancy stage, what is doing is protecting brain perfusion. So the vagus nerve and the sympathetic nerves are designed to constrict to increase volume and vasodilate to decrease things. So if they think, and it's a counterbalance. So if they think that, for example, the patient with a sympathetic drive, right? If they have that big, massive heartbeat, okay, and you just one impulse have this blood flow going to the brain, immediately the carotid body is going to think, oh my God, they're going to stroke. There's this massive, hypertension, and that it releases the vagus nerve, right? And so this autonomic nervous system happens so instantaneously, right? And while we can't control that, right, we have to do our best to control other parameters that we can control, to make sure that those are also not triggering.
Thank you. So I know that we are already at 1:17, so I think I know we have other questions. I'm sorry that we weren't able to get to them all. I just wanted to ask, someone asked that they were interested in seeing you as a patient and were curious if you take insurance. If you could just give us a little bit of information about your practice and how patients who are interested in seeing you should best go.
So, I practice in Burbank, California. That says I do telemedicine across the state. I can't cross state lines. And so people who just want to get advice from me can also, arrange for telemedicine visit. As I showed you, we do pretty sophisticated testing in the office. And so ultimately it's good for them to come in and see me in person. We take all PPOs and Medicare, EPOs and so forth. I don't accept HMOs, but we do have a fairly a reasonable self-pay fee as well. So I don't ever want, access to be a factor.
We appreciate that. Um, Thank you so much for being here. It was very informative. Really appreciate it. And thank you for the care that you are providing to the dysautonomia community. Thank you so much, Dr. Thaik.
Thank you.
All right, and thanks everyone for being here. Hope you all have a good rest of your day.